Vikas?
Yeah.
What's the order again?
Damian, number one, yourself, and then Patrick.
I think it's no discussion after each individual talks other than Paul's. The rest of us going to talk in the end. Yeah. Okay.
Right. Yeah. Right. Good evening, ladies and gentlemen. It's just gone 18:31, so we'll kick off this evening's webinar. A very good evening, ladies and gents, and welcome to the fifth episode of the British Hip Society Midweek Special. I'm Vikas, Khanduja, consultant orthopedic surgeon in Cambridge and chair of the Education Committee in the British Hip Society, and it is indeed a pleasure to welcome all of you to this webinar. Now, our aim with this series is to bring to you clinical cases and discuss nuances of decision-making and management from key opinion leaders in the field of hip surgery in the UK, so that we can continue to fulfill the Society's manifesto of sharing knowledge and improving patient care. We've had 4 excellent sessions on primary total hip arthroplasty, and the session today will be the first one in the young adult hip series and will be focused on femoroacetabular impingement, perhaps the most common indication for hip arthroscopy in the UK. Now, helping me with this session today are 3 excellent speakers, Professor Damian Griffin from Warwick, Paul Gaston from Edinburgh, and Patrick Carton from Ireland. We are also delighted to be collaborating with OrthoTV Global for this series and welcome all the viewers from the Asia-Pacific region who are able to watch this event streaming live at no cost via OrthoTV. Thank you, Ashok. We strive to make every session as interactive as possible. Therefore, please do post in your comments and questions in the Q&A box. Our panelists will address these questions as we go along and choose some of them to be discussed live at the end of the webinar. For those of you who are not able to join us live this evening and are enjoying the sun outside, we do have the option of on-demand viewing via our educational platform, Khanduja. So please do log in there if you're not logging in live. Finally, a big thank you for nominating us in the Best Webinar Series for the BOTA Awards. And once again, a very warm welcome to all of you and hope you enjoy this series. Now, it's a pleasure to introduce our first speaker for this evening, Professor Damian Griffin. He does not need any introduction in the world of young adult hip surgery, but essentially he's a professor of trauma and orthopedic surgery at the University of Warwick. He's trained in Cambridge, Oxford, and the United States. He leads one of the largest orthopedic research groups in the UK, testing the clinical effectiveness of surgery. Now, Damian's clinical interest is hip surgery in young adults, and most of his research in the last 10 years, including the Warwick consensus paper and the fashion paper, have been focused in this arena. His passion is for hip preservation surgery, including hip arthroscopy and periacetabular osteotomy, and he provides the largest specialized service in this field in the UK. Pleasure to have you here, Damian. Over to you.
Thank you, Vikas. It's a real pleasure to be here as well. I'm very, very pleased to be able to take part in this because it's great that it's getting out into the community and more people are interested in femoroacetabular impingement syndrome and young adult hip surgery. I run a young adult hip clinic in Warwick in the middle of the UK, and we treat lots of different things, some soft tissue, some within the hip joint. But the one we're going to focus on today is femoroacetabular impingement syndrome. Start with a case. I'm going to tell you about a 21-year-old man who came to see me a little while ago. He was a squash player, but he was getting increasing pain in his right hip. This had gradually been getting worse, and it got to the point where he could no longer train for squash and, in fact, couldn't play matches. And this was a big deal for him because he was on the fringes of the GB squad. After a bit, not only could he not play squash, but he found it painful to drive a car, painful even to walk up and down stairs. His father had had a similar history and then had ended up having a hip replacement in his 40s. Now, this young man, when I examined him, had a pretty good range of movement generally and quite good control and strength around his hip, but reduced internal rotation inflection and a positive impingement test. A plain radiograph is pretty unremarkable, but an MRI scan showed a partial thickness tear of the anterosuperior labrum. And on a CT scan, we can see a cam shape or a bulge of the bone at the head-neck junction, the anterior aspect of the joint. Now, if we had a look at that cam shape with an image intensifier, while we move his hip with him sedated, you can see that the bulge goes underneath the labrum, but then comes into contact with the edge of the acetabular rim. And this contact here is what causes the damage within the hip joint. So we did an arthroscopy, and if we have a look inside his hip, just to orientate you, the femoral head is the big white globe sitting at the top of the picture, and underneath is the acetabulum. Coming around to the front of the hip now, and you can see the labrum at the edge of the socket, and towards the bottom left of the picture is the acetabular articular cartilage, but I'm probing a failure point, a crack between the labrum and the articular cartilage at that junction. And I'm showing you this patient because this is what we think is probably the earliest sign of damage in the hip joint. This is very minor damage, but you can see that in a 21-year-old, this is very concerning. Now, what we really need to do is to remove this bulge of bone which is causing this damage before it gets any worse. You can orientate yourself with the 3D CT in the top right. We're looking down from the top of the right hip, and the top of the picture there, and the bulge is at the anterior aspect. On the right is the femoral neck, and on the left is the acetabular labrum. And when I flex and internally rotate the hip, that bulge goes under the labrum, pushing it out of the way, and then it comes into contact with the rim of the acetabulum. And we need to get rid of that bulge, and so I'm using a burr here just to mark out where the edge of the spherical part of the femoral head is and remove all the bone that's lateral to that. This is a bit of a three-dimensional problem, especially on a two-dimensional screen, but it's important to make sure that we end up with a very nice shape. And you can see as the ball rotates into the socket that the labrum is just about touching the surface throughout that range of movement, but it's not being deformed by it. And then we can close the capsule with some sutures, and we're done. Now, after this operation, he started physiotherapy the next day, and he was able to return to training for squash in 9 weeks. And he's done well because he now plays for England. Now, 6 months after the surgery, he had a slight ache after playing a back-to-back weekend of matches. That was the extent of his symptoms. And at 3 years, even that had got better. So he still has occasional discomfort, but it's nothing like what it was before, and he's been able to get back to sport. So what is femoroacetabular impingement syndrome? Well, you might say the ball and the socket don't fit properly, but you've also probably heard terms like cam and pincer and labral tears and condyle damage. That's not really good enough, that rather vague concept. So a group of us got together a few years ago and produced the Warwick Agreement, which is a set of criteria for making this diagnosis. And this paper is available with a link that we're putting up on the Zoom chat. So here's the definition that we came up with. And you can see this syndrome is a triad of symptoms, signs, and imaging findings. And it represents symptomatic contact between the proximal femur and the acetabulum. Now, all of those are important features, so let's build it up. To make the diagnosis, you need this triad. It begins with symptoms, and the primary one is hip pain, although some people have clicking or catching or stiffness or giving way. Now, the pain is most often felt around the hip, and they use the classic C sign, or they point deep into the front of the groin. But be aware that sometimes it's in other places, going down the thigh or into the buttock or even the back. The second part of the triad is clinical signs. And the one that seems to be most valuable is an impingement test. Now, this is painful in anyone who has arthritis, or indeed many hip conditions. And it will also be painful if you do it roughly in anybody. But if you do it very gently and carefully, and the patient doesn't have arthritis and it's positive, then that's a sensitive test for femoroacetabular impingement. And the third item is radiological findings. Now, you'll probably do a plain radiograph of the pelvis, and on the AP view, you might not see very much. But if you look very closely, in the case of a cam shape, you might see a prominent area of bone just outside the sphere of the femoral head. And in a pincer, you'll be able to recognize prominent parts of the rim. A lateral radiograph is often very helpful, especially in the cam case, because you can see the bulge at the front of the hip much more easily. Three-dimensional imaging is going to be useful if you suspect this condition, and an MRI scan will show you the soft tissue, including the labrum, and a 3D CT very easily shows the shape of the proximal femur. And finally, you may find a local anesthetic injection very helpful. I use it a great deal. So injecting some local anesthetic into the hip joint, and before and after doing that, put the patient through their normal activity and the one that brings on their familiar pain. And this may require some imagination. You can see the lady on the bottom right only got pain when she rode her horse. We didn't bring the horse to the hospital, but we did get her to bring her saddle. So get this triplet, this triad of symptoms, signs, and imaging findings before you make the diagnosis. So what can you do? Well, think about treatment options. So conservative care could be advice about activity. We could have told that chap to just stop playing squash. Painkillers, possibly injections. We increasingly think that physiotherapy is going to be more helpful than just conservative care, and it's going to need to be a very directed program of physiotherapy. And then finally, surgery is an option, whether that be arthroscopic surgery or open surgery. And in the last few years, a big question has been, how do you choose between these options? Which is the best option for a patient who presents to you? Vikas asked me to talk about the fashion trial. And this was a large randomized controlled trial testing the question in patients with femoroacetabular impingement syndrome, what's the effectiveness of hip arthroscopy compared with physiotherapy? And this question was set by the National Institute for Health Research and funded by them. Now, we ran this trial from Warwick, but all over the UK. We recruited patients who had FAI syndrome and in whom the surgeon felt that arthroscopic surgery might be helpful. Importantly, these patients all had little or no degenerative change in their hips. And then we randomized them to either hip arthroscopy or personalized hip therapy. Now, personalized hip therapy, or PHT, also in the links that I'm going to give you later, is a physiotherapy program that's very individualized and progressive. So we thought it was the best possible physiotherapy program in the NHS at least. The design of the study was pretty conventional, a one-to-one randomization into the two groups. And our main follow-up point was at 1 year, the IHOT33 score, which is a patient-reported score of pain and function suitable for young adults with hip problems. It cost about £2 million to do this, 22 hospitals across the UK, 26 surgeons were involved, and about 24 physiotherapists. 348 patients agreed to be randomized, and we split them in half randomly into the two groups, and half received personalized hip therapy and half arthroscopy. Technically, this was a very successful trial in that a small proportion of patients crossed over, and in fact, only in one direction. These were all patients who felt that physiotherapy wasn't helping and they wanted to have surgery. But a high proportion were followed up. 92% is very high for this sort of surgical trial. So what did we find? Well, these are the IHOT scores at the beginning of the study. And you can see surgery group in orange and the PHT group in blue. They're exactly the same scores at the beginning as you'd expect in a randomized trial. But 12 months later, both groups have got better, but the surgery group has got better more than the physiotherapy group. And put some numbers on that. The raw difference is 9 points on the IHOT score, and adjusted for all potential confounders, so making it as low as we could to minimize the risk of error, we found an effect size of about 7 points, which is substantially above the minimum clinically important difference on the IHOT scale. And the p-value for that, in other words, the statistical significance, was a very low p-value, very highly significant. And we published that in The Lancet in June 2018, and it's been very well received around the world, with many people thinking that it's very good evidence of effect. So our conclusion was that in patients with femoroacetabular impingement syndrome, hip arthroscopy works. So to conclude my talk for this evening, I would urge all of you to think about FAI syndrome in anyone with hip pain who doesn't have arthritis. Of course, most of those people will be young, but bear in mind that this can be treated successfully, and I believe it really should be. Thank you.
Thank you very much, Damian. That's a perfect introduction to FAI, a classical case, and results from the fashion trial as well. We'll quickly move on to our second talk, and our second speaker is Paul Gaston, who is originally from Northern Ireland and went to medical school in Edinburgh. He undertook his surgical training in Edinburgh, and then his orthopedic training in Oxford and Edinburgh again, and then finally his specialist fellowship in hip surgery in Brisbane, Australia. And then he was appointed consultant at the Royal Infirmary in Edinburgh in 2004. Since then, he's been undertaking hip arthroscopy over the last 15 years and has a specialist practice in young adult with hip problems. And he's also recently been appointed as a member of the user group on the Non-Arthroplasty hip registry. Thank you very much, Paul. Damian, if you could kindly stop sharing your screen, and then we'll get Paul to share his. Brilliant. Thanks, Paul. Need to unmute yourself, Paul.
Thank you, Vikas. Sort of novice error there. Thank you, Damian, for an absolutely fantastic talk. And it's actually impossible for anyone to follow that when talking about femoroacetabular impingement syndrome. So I'm not even going to try to. I'm just going to present some results of some smaller localized research that we've done and make a bit of a plug, at least to the UK surgeons, for the Non-Arthroplasty hip register, which is a very important database UK-wide. So Damian talked about various scoring systems, and specifically the IHOT 33, which is the International Hip Outcomes Tool. The National NAHR, the Non-Arthritic Hip Registry, uses that outcome tool in what they call their minimum data set. It also measures a couple of other things, including quality of life scores and a visual analog score for pain. But it actually, the data entry for the NAHR is very, very minimal, and it's not arduous to do this. You just actually need to do it for all the patients that you're doing these surgeries in, and then submit your data. And it's actually in the National Institute of Clinical Excellence guidance for those who do hip arthroscopy in the UK. One of the advice contained in there is that surgeons should submit their data to the NAHR if they're doing that surgery. So what we did was we wanted to assess the outcome of hip arthroscopy for femoroacetabular impingement using that minimum data set of the Non-Arthroplasty hip register. So myself and my team looked at our data, and we found that using that very minimum data of IHOT 12, which is a shortened form of the 33, and only 12 questions to answer, but has been validated as being equally as good, EQ5D and VAS, there was a significant improvement in those three factors. And so the data that you get from the NAHR is meaningful and useful. But the most important thing that came out of that study is that we also asked patients whether or not they would recommend this treatment to other people. Now, when you ask patients or any group that question, you get, say out of 100, you get a bunch of people who would recommend it. You get a bunch of people who say, I don't have an opinion. And you get a bunch of people who say, I wouldn't recommend it. And what you do is you ignore the people who don't have an opinion, and you then take the people who would recommend it and you take away the number who wouldn't recommend it to get you the thing called the net promoter score. And government and politicians are very interested in this type of thing because it can actually be used to compare one type of service with a completely different type of service. So if you look at what I've put up on the screen there, the net promoter score in the UK for the Apple iPhone is 63, positive 63. So a lot of people are recommending it and not many people are saying it's no good. Whereas if you look at British Gas or indeed any utility provider, all the net promoter scores for them are all negative. And in fact, we found the net promoter score for our patients having had a hip arthroscopy a year before was 70. So more people would recommend having a hip scope than they would an Apple iPhone, which is a very important message to get out there. Overall, 76% of patients were satisfied with the outcome in that study at 12 months. Now, one thing that we've started to notice with the IHOT score is that it has a kind of a ceiling effect. And we were very fortunate to have a Swiss fellow who came to work in Edinburgh with us for a while. And he was actually one of the originators of a thing called the Forgotten Joint Score, which you may well have heard of in the context of arthroplasty surgery. And it's really about how much patients think about their hip before and after a procedure. And so we looked at the Forgotten Joint Score in our patients compared to the minimum data set from the Non-Arthroplasty hip register, and you can see that the patients have a really big improvement in their Forgotten Joint Score after hip arthroscopy. And for us, the ultimate outcome at 12 months is satisfied and forgotten about the joint. And in fact, one of the reasons you know that that's the case in a lot of patients is that when you send them the 12-month questionnaire, most patients or a lot of patients ignore it and you have to chase them because they've forgotten all about it already. We looked then more recently at a thing called the patient acceptable symptom score or symptom state threshold for the FJS, and it's actually quite low. We did a receiver operating curve type analysis to work out which gives us the best numbers, and the patients only have to get to a score of 38.5, which does mean they have to, or they are thinking about their hip a bit, but they're still fairly pleased at that level. But you can see, in fact, that in the box plot there, a lot of patients achieve a lot more than that after hip arthroscopy. And just like I mentioned before, I think the IHOT score suffers a bit of a ceiling effect, especially in the younger high-performing athlete group. However, what about patients who don't do so well? And I'm going to try to illustrate that with a case, and also I need help from the expert panel on this case. So these are the images pre-op of an 18-year-old girl who I operated on for the first time in 2018 with typical symptoms and signs. She had the full triad and she didn't seem to be particularly slack and lax. And so I thought it was a very straightforward case. She had a fairly big tear. I'm sorry I don't have the arthroscopic images, but I went ahead and undertook a repair with anchors and removed some impinging bone on both sides of the joint. So hopefully no real controversy there. And she did very well after the operation. She was one of the ones with a good outcome, seemed very pleased, and she did well for about 18 months after the surgery. then 18 months later, so at the beginning of 2020, she presented again with the same symptoms and signs, and this time a significant click, which I kind of ignored at the start, and I regret that now because I'm going to show you a little video of her. And because her symptoms and signs were so similar, my working diagnosis was a failure of the repair. And so she had the same investigations. Again, you can see that part of the femoral head's been removed at the first operation. The labrum was reported as looking okay, but she still seemed very genuine to me. And you can see on this image the anchors are in place. But I actually went ahead and did a redo hip arthroscopy for her in 2020. And that time, because I'd already tried to repair, she still had symptoms. I just undertook a labral debridement and took off some residual impingement after that. Sadly, immediately post-operatively, once she got up on the day of surgery, the patient was very clear that her symptoms were identical and unchanged. And I was very disappointed by that, and so was she. So this is how she presents now after 2 hip arthroscopies. And I would like you all to try and make the room that you're in as silent as possible so that you can hear the problem in this lady, because this is an audible problem, which I've actually not really come across before. So I'll just play that video now. Could you all hear that? At least the panel, could you hear that? Damian, could you hear it?
Yes.
Right, okay, good. And because you could hear it. So, but you can see that despite that very audible noise, she sort of smiles at the camera, although she still talks a lot about pain. So since then, I've gone on to investigate her fairly extensively. This is her current plain X-ray. I thought the joint space still looked okay. This is her MRI scan, and with 2 hip arthroscopies, she's probably got a little bit of defect in the capsule, although, the muscles are still there. This is her 3D CT with reconstruction. You can see the cam excision, and I don't think there's too much residual bone there. And remember, she has no labrum anteriorly now, or it's certainly been trimmed down quite extensively here. She had a dynamic ultrasound by one of our good radiologists, and he couldn't see anything moving abnormally around her hip or clunking. I brought her in as a day case and did a psoas tendon injection, which made absolutely no difference to her symptoms. So this is her now. She's 21. You can see she still smiles and almost laughs about it. She's embarrassed about it. And because of this problem, she barely leaves the house. She's dropped out of uni, and she uses a wheelchair to go out and about. And a lot of that, I think, has to do with the fact that she's really embarrassed by the clunk rather than pain itself. So I'm really looking for some advice here from the panel, and I'd welcome anything that you guys might suggest.
Paul, it's Damian here. I think you're very careful to use the word clunk, because it's good to distinguish between high-pitched clicks and lower-pitched clunks. And that seems to be the case, that high-pitched clicks usually come from within the joint, whereas clunks are more often the psoas tendon or the iliotibial band. So for everyone listening, I think that's a useful distinction to make, to decide whether this is a click or a clunk. And listening to that, that's a clunk. So I suspect it's not coming from the hip joint. And you've already had a good look at psoas. Have you had a look at the iliotibial band?
Yeah, because she can, obviously, as you can see, she can do that clunk at will. So I've walked beside her, and it is definitely not external snapping of the hip. It's definitely internal. And so I suppose what I'm asking you guys is, the only option I have left for this girl is to try a psoas tendon release. Should I do that? Should I do that at the level of the hip? Should I do that more distally? I wonder if anybody's got any advice on that. Patrick?
Paul, I was just going to ask, the clunk seems to be appearing when she is an extension rather than flexion. So she's extending the hip. And the first thing has been the 3D CT scan did look as though the anterolateral rim looked quite deficient, that last scan. And the fact you've debrided some of the labrum now at this stage as well. And did you do a capsule repair?
No.
So my first concern would be this lady is subluxing a little bit forward her femoral head in extension when she's walking, and one of the things that I would do would certainly be considering her laxity and her stability, and for that reason I certainly wouldn't be doing a psoas tenotomy that can make things worse. And do you remember during the arthroscopy was she quite lax when in distraction at the time of the surgery?
And her Beighton score right at the start was 4. So,
yeah, so because the last MRI scan again also the capsule looks very deficient, and the anterolateral capsule looks very deficient. So to me, the first thing I would be concerned about that you have some degree of instability, and that's where I would be looking.
And how would I make that diagnosis?
Again, first of all, the clinical examination, I'd be looking for an anterior apprehensive test. I would be putting the lady on her side and bringing the hip into extension into adduction and trying to sublux that femoral head forward and see if that replicates on her pain. I would look again at her general range of movement compared to what was before surgery. And certainly at this stage, I would be reviewing the scans, looking at the capsule both anteriorly and anterolaterally to see if there's deficiency further around. There's a lot of pooling of contrast in the MRI scan. But certainly the fact that there's been 2 resections of the anterior lateral rim and there's been some debridement of the labrum, the capsule hasn't been repaired. I think to me that would be the first place I would look, Paul. Doing a capsule repair or plication to offer some stability. She may need a labral graft as well. All in an attempt to try and improve the suction seal and stability of the hip. But I don't think it's a psoas just by the way she's walking.
Okay, thanks, Patrick. Right, I think we should probably move on from that now. We can always discuss this later. So, not that this has anything to do with this patient, but another thing we've looked at is how aware patients are of symptoms pre-op and also how long that lasts for, and whether there's any correlation between that and indicators of mental health. And so we've been looking at the EQ5D anxiety and depression dimension score, and you can see that the patients who have hip problems, who are on the waiting list for a hip arthroscopy, do have worse scores, and there are more of them that are a bit anxious or a bit depressed. And about half of the patients on our waiting list for hip arthroscopy report some level of anxiety and depression, which is probably not a surprise given the fact that they're in pain and have symptoms in their hip. And if you look at the different things that are associated with that, these were very strongly associated with the patient's score pre-op, but also with their body weight and smoking status. So there's a lot more to this than just having a sore hip. Now, Vikas, our chairman and host tonight, produced a beautiful paper that was published in the British Journal last year, looking at the risk factors associated with poor outcomes following hip arthroscopy. Now, in the pictures, he's obviously shown a very nice example of a patient with no joint space, and I hope nobody would consider doing a hip scope in a patient like that. Interestingly, the most favored group, and I found this anecdotally from my own experience, are patients who are athletes, especially professional athletes. They seem to do really well after hip arthroscopy, and their recovery can be very quick. And I think that's because they have different motivations than perhaps the non-athletic population. He also found that patients who had a good response to a preoperative local anesthetic injection that Damian showed, again, had a good outcome after surgery. Then there's a lot of factors that make it less favorable for patients to do well. The older you get, interestingly, females, not so good. Patients with mental health issues already, as I showed, in that previous slide, smoking, obesity, heavy alcohol intake, interestingly lower pre-op scores, and hypermobility, which may have been an issue in the patient that I've just showed. And then looking at the joint itself, so if they have a narrower joint space, and subchondral cysts, I think, is important to highlight, because you can see patients quite frequently who look like the joint space is good, but if you look carefully at plain x-rays and definitely on their cross-sectional imaging, you can see subchondral cysts. And I don't think it doesn't matter what you do to the cam or the pincer or the labrum or the capsule in those cases, I don't think hip arthroscopy can treat subchondral cysts independently. And then other deformities around the joint can have an effect, including dysplasia, different version of the socket and femoral neck, and also a big cam lesion. So Vikas asked me to just make some take-home messages, and I would tell you this. 8 out of 10 patients are either satisfied or very satisfied with the outcome of hip arthroscopy at 12 months post-op. And athletes do particularly well. And this is an example of an athlete who had a hip arthroscopy in this hip, who recently performed very well in the Lions Tour. But there are a group of patients who don't do so well, and you've got to be careful with those. And I would suggest probably not undertake surgery in them. So the two main things are either factors in the joint, if there's any significant arthritis, but even subchondral cysts without joint space narrowing, or significant deformity, those problems need a different type of treatment. And then patient factors, which can have an effect on the outcome. So older, females, obesity and smoking, and of course, hypermobility. Thank you.
Thank you very much, Paul, and for the case as well. We'll move on swiftly to the last speaker for the day, and that's Mr. Patrick Carton from Ireland. He's a consultant orthopedic surgeon specializing in sports-related hip, groin, and knee injuries, and also reconstructive surgery of the hip joint at the Hip and Groin Clinic in UPMC Whitfield in Waterford. Now, prior to his move there, he held the position of the clinical director of trauma and orthopedic department in the NHS Southern Health Trust in Northern Ireland, and he established the unit there as well. Now, in recognition for his contribution to both research and clinical aspects of sports medicine and joint preservation, Patrick was awarded the Fellow of the Faculty of Sports and Exercise Medicine by the Royal College of Surgeons in Ireland, as well as the Honorary Fellow of the World Society of Sports and Exercise Medicine in 2018. Patrick was also appointed as an honorary research associate at the Department of Health, Sports and Exercise based in Waterford Institute of Technology. And most recently, he's been appointed director of the Orthopaedic Sports Medicine for UPMC for the whole of Ireland, and has a wealth of experience in young adult hip surgery. It's a pleasure to have you here, Patrick. Over to you.
Thank you, Vikas. I'll get started straight away here. I'll share my screen. Okay, thank you. I'm just going to spend the next 10 minutes talking about femoroacetabular impingement in athletes, in particular those with a groin discomfort and groin symptoms, as well as symptomatic FAI. This is a typical a presentation. This is a young 23-year-old elite GA sportsman. He's presented with a 2-year history of increasing stiffness in both of the joints of his hips and with loss of flexibility, post-activity, groin discomfort, and lasting over 2 days following training and playing. He just before he was referred, he developed a 6-week history of acute lower abdominal and groin pain, unable to twist and turn, accelerate, sprint, painful coughing and sneezing, very difficult out of bed in the mornings after training. And just prior to coming to the clinic, he was unable to train and play. He was referred to my clinic by his team doctor as a possible Gilmore's groin or sportsman's hernia, and suggesting the need for a surgical intervention. Clinical signs in examining the hip were quite typical of underlying FAI. He had reduced flexion, internal rotation, and adduction. He had a painful flexion, adduction, internal rotation sign indicating some degree of labral pathology, and also had pain and resisted straight leg raising. Because of his recent history of inguinal symptoms, we examined the inguinal canal. We found he had a widened and tender external inguinal ring. He was painful on cough impulse testing and tender over the pubic tubercle. He also had pain over the deep ring on resisted sit-up exercise and tender along the rectus abdominis border. And it's important when you have a history of inguinal symptoms in these athletes that you do a formal inguinal examination. He also had some discomfort radiating down into the left adductor, and this is the picture of the left thigh here. This is the muscle tendinous junction. This is the origin of the adductor on the pubis, and both these were tender on palpation. This young athlete also had weak and painful adductor strength test, both in full leg extension and with the hip and knee flexed to 45 degrees. So all athletes coming to the clinic will have a standardized X-ray series. That includes an AP pelvis, and this is an AP pelvis of his left hip. As you can see, the yellow angle indicates the alpha angle that Damian was talking about. And here we have a lateral center edge angle of 48.7. And this is the lateral center edge angle to the source seal, which is 30.3 degrees, which we would consider normal. We also organized for a done view, a 90-degree done view. You can see the lateral rim deformity here, but he has a done alpha angle of 71.2, which is abnormal. Greater than 55, we consider abnormal. And then we use a false profile view, and you can see the large anterior rim deformity, which brings the anterior center edge angle to 55.8 degrees. But to the source seal, the edge of the weight-bearing surface is at 32.5 degrees, which again, we'd consider normal. Standard investigations for our patients will include an MR arthrogram, and here you see a chondrolabral tear on the coronal views. He does have some early chondral changes as well. We'd expect to see some damage to the articular surface at arthroscopy. On the sagittal views, you see he has a labral base injury, this large area of signal in the labrum indicating a trauma to the base of the labrum or instability, depending on the nature of the pathology. For some of the athletes who are maybe mid-season or coming towards the end of the season, who are trying to get back playing the last couple of games and want an early return to sports, where a repair of the groin may be undertaken, we would look at a dynamic ultrasound scan, looking at the difference between a posterior wall bulge and a potential direct hernia. Very important to distinguish between a hernia and a non-hernial situation. Pubic bone edema, adductor tears can be seen on MRI groin, which again would be organized to look at adductor-related tendinopathy. So this 23-year-old athlete had a complex groin and hip issues. He has an adductor tendinopathy. He has evidence of an inguinal disruption and has symptomatic FAI. So how do we manage this? Well, there is no general consensus as to the best surgical management for dual pathology, as we call it. The literature, most have come from North America, would tend to favor a staged, simultaneous groin repair and FA correlation. With better outcomes, return to sport. From these reports, if you repair both the groin and deal with the impingement separately in a staged fashion. The general management options when patients do come to the clinic rarely involve non-surgical. They've been through most of the rest activity modification. They've been through the physiotherapy with their team doctors and the team physiotherapists. By the time they come to the clinic, really they're at the stage where surgery is being recommended. We rarely would do too many diagnostic injections, as we feel just with a good clinical examination and proper imaging, the diagnostic information is very much clearly there. We do sometimes, when athletes are trying to get back to their playing maybe the last couple of games of the season, would do a pubic cleft injection, which often will help settle down some of the inguinal and adductor-related symptoms and allow them to get back playing towards the end of the season, where we can better identify the problems and deal with them. Surgical options for these athletes will involve either performing an inguinal groin repair, performing an adductor detensioning, trying to take the tension out of the adductor to try and over chronic inflammation at the site of origin. Arthroscopic FAI correction, dealing with the primary driver of a lot of the problems that these patients have. And as we've talked about in North America, they prefer a staged groin repair and hip surgery, sometimes one groin before the hip, sometimes hip before the groin. In this 23-year-old athlete, we performed an arthroscopic FAI correction as a sole procedure. And this is what we do with all of our athletes now with dual pathology. The goal of managing FAI in athletes is to achieve an impingement and a pain-free range of motion. earlier this year, we published our 2-year outcomes and predictors of achieving MCID with treating sports-related FAI and competitive sportsmen. The primary aspects of the sports hip repair is to preserve the chondrolabral junction and preserve the labrum as much as possible. We do this using a hook probe. We reflect the labrum like peeling a skin off an orange, pulling it back off the acetabular bone. And we developed this fibrovascular cuff, and this is the cuff that we use to repair the labrum. We try not to put any sutures through the labrum or around the labrum. This is the large pincer deformity we saw in the previous x-rays. Just using a 4mm burr. And this is a small rasp. It's important to smooth off the edges of your resection so you don't avoid any sharp areas. This is an intraoperative image. This is the large crossover here. We're just reversing the crossover, removing the abnormal anterior rim and normalizing the rim. So the next stage is to preserve and repair the labrum. This is a picture of the labrum after repair. You can see there's a nice confluence to the chondrolabral junction, and there's no suture around the labrum. We call this the labral cuff fixation or an anatomical labral repair, and both have been published over the last couple of years. Essentially, what a cuff repair is to protect, again, the chondrolabral junction. We don't put any suture through or around the chondrolabral junction. We use a small spinal needle to select the point of entry of our suture between that fibrovascular cuff and the very periphery of the labrum. We use a loop PDS just to pass and shuttle that suture around that periphery. We only ever need 2 anchors to repair the labrum, because if you keep the chondral labral junction intact, then that offers most of the support to the repair. The sutures are kept well away from the joint line. And the labrum after repair is a free flap. If you put loops around it or put suture through the labrum, it hardens the labrum, it elevates the labrum, and makes a less of a good seal, and it stops the labrum being mobile. So this is the removal of the pincer in this young athlete. This is the center edge angle to the source seal is 32.5 before surgery, and we've brought the angle back to its true shape right at the edge of the source seal. So then, at about 71% of our athletes, we do have some form of cam resection. We do have 100% pincer management in all the athletes. We focus most of our attention on the rim. You can see here on the left the intraoperative image is just restoring the natural offset to the femoral head neck to minimize any risk of impingement. The deformity correction here, again, the done view shows 71.2 before surgery, 44 after surgery. So there's a good a resection of the cam deformity. So capsule management, we feel is very important. We have published the largest comparative series of cases looking at a repair versus no repair. And really, the routine intercapsular repair did not lead to any significant clinical benefits, other than in very young athletic patients like this gentleman, where we do now always use a single stitch capsular apposition. So we avoid any type of T capsulotomy. We avoid making any large capsulotomies. Everything's done through small capsulotomies to preserve the capsule as much as possible. And we use a single stitch at the end just to oppose rather than tightly repair. The rehab in this case is fairly straightforward. They're on a stationary bike immediately. We encourage swimming after 10 days, running after 8 weeks, and back to sports training at 12 weeks. Long term, we tend to avoid squatting, lunging, and deep leg presses, and we avoid stretching the hip joint and try to optimize the strength. So the pathogenesis of dual pathology, we believe mainly this is due to the abnormal and progressive bony hip morphology, alters the hip biomechanics. This leads to stiffness, limitation of movement, and during athletic play, twisting, turning, running, sprinting, this causes increase of the pelvis, increased shear stress across the pubic symphysis, increased strain and injury to the posterior inguinal wall, and therefore correction of the FAI may restore normal hip biomechanics, therefore reducing the shear and strain both across the pubis and the posterior inguinal wall, and therefore relieving symptoms. So we published only a couple of months ago in the American Journal of Sports Medicine a long series of 113 competitive athletes with dual pathology, both with inguinal disruption and symptomatic FAI. There's a minimal 2-year follow-up, and for all patients who were treated with hip arthroscopy alone as the index procedure, 89.2% were successful. Only 10.8% required a further groin repair. And we looked at the patients who had both procedures versus hip arthroscopy alone, and there was no difference in the clinical outcome between those two groups. So in athletes presenting with inguinal or adductor-related groin pain, always examine the hip. It's very important. In those with dual pathology, I would ask you to consider FA correction as a single and primary procedure, as it's very likely to relieve a lot of the pressure on the groin and on the adductor if the symptoms are present. With regard to sports hip repair, a minimal capsulotomy, avoid a T-capsulotomy if you feel it's caused too much disruption to the capsule. Preserve the chondrolabral junction. Avoid loop and intersubstance repair if possible. Correct the lateral and, most importantly, the anterior center edge angle. We tend to avoid any chondral debridement or microfracture. We leave the cartilage as it is. Anatomical cam repair, use or deformity correction, use X-ray the whole way through, and capsular apposition rather than plication. Thank you very much indeed.
Thank you very much, Patrick. Again, that was excellent. Now, we've had 3 fantastic talks, but the outcome of that is that we are running well over time. So we'll try and limit our discussion to the next 5 to 7 minutes and then call the session to a close. So fantastic talks, all 3 of you. One quick question, which has come in from the audience as well. Obviously, patient selection is key. What do we do with a 28-year-old male with a large cam lesion and grade 2/3 tonus OA if he presents to the clinic? Obviously, we've seen results of the fashion and fate. If you've got no arthritis, hip arthroscopy does well, but you presented in the clinic a lot of the times with these young patients who have actually got grade 2 or grade 3. How do we handle those patients? We'll start with you, Paul, then go on to Damian, and then Patrick. We'll get views from everybody.
I don't have any evidence for what I'm about to say, but I think in young male athletes who have a lot of groin pain, hip arthroscopy is worth a try, even if the joint's a bit narrow, because even with just a debridement of both sides of the joint and the soft tissue, they can often do very well, at least for a while. So if there's a 2 in front of their age, if they're in their 20s, I would still consider that for some patients. A lot of it depends on their symptoms. If they only have post-activity aching that still is there the next day, they probably won't get better with a hip arthroscopy. But if they're sore in the middle of their sports activity, then they might.
Thanks, Paul. Damian?
So if they are complaining that they can't be active, then I think it's quite helpful to explore carefully what their range of movement is. And sometimes I'll use an image intensifier in the way I showed. And if I could convince myself that I could make a significant difference to their range of movement, then that might be a reason to perform hip preserving surgery. One of the difficulties is that it's sometimes really difficult to do that adequately by arthroscopy when they have extensive arthritis. And so you might be thinking about doing an open procedure, perhaps with a surgical dislocation, in the face of knowing that there's significant cartilage loss. So that's a big call to make. And it really only makes sense in people for whom activity is a critical part of their lives.
Thanks, Damian. And Patrick?
Yeah, I would tend not to operate, and certainly if it's grade 3, I would generally ask them to avoid activities that cause their issues as much as possible. If it's a case of they cannot function day to day, even with simple activities, then I would agree with Damian and Paul. I would then consider some intervention to try and relieve some of the pressure on the hip joint. Sometimes if they have a lot of stiffness and you relieve the pressure and you give them more movement, that can sometimes give them more pain. So it can be a vicious circle. But saying that, we've looked at our tonus 2 and 3 hips 10 years now from surgery, and we're ready to submit an article actually based on this. So, and it's something like 59% are still surviving and happy 10 years from surgery. So, again, it comes down to really picking the right patients. Again, they're young is very important because age has a major factor, and we found that in our own results. Definitely, I wouldn't say no. I'd say that there's a good chance that you relieve some symptoms in the right cases. Absolutely.
So would it be appropriate to say that there is true equipoise here? We don't know what to do in these patients. Paul, you wanted to say something?
Quite true, Vikas. What I was going to say, though, the corollary to what Patrick, Damian, and I have all said, which is where we might consider it in that specific patient, is if you see a non-athletic, non-active female much over the age of 35 with post-activity aching pain rather than sharp catching pain in their groin, they do not do well with hip arthroscopy, even if the tonus grade isn't that bad. So that's the patients you need to watch out for, is those slightly older female patients. They can really be, you can really get into trouble with them by promising them too much and not achieving it.
True. That's why I chose.
I would say that this is probably an area where, if you're working as a young adult hip surgeon, a hip preservation surgeon, it's really helpful to have some multidisciplinary team meetings with arthroplasty surgeons as well, because they will say to you, as you will know, well, hang on, I can completely get rid of this patient's pain with one operation. And if they're completely disabled at the moment, okay, there might be issues later in their lives, but I can make a big difference to them right now. So talking that through and considering a plan that makes sense for that particular patient with all of the different specialists involved, I think is very helpful. So we don't get stuck in, back ourselves into a corner of trying to preserve every hip.
Agreed. Thank you all. 3 quick questions. First one is from Ed Dickerson. In mixed impingement, how do you decide whether to treat the cam, pincer, or both? Patrick, since you're actually doing pincers on everybody, probably best that you can take on this question.
Yeah, I think certainly the acetabulum is where our focus is, and we're doing less work on the femoral neck unless there's a very clearly defined cam, very clear. And cams are I think they're overdiagnosed. I mean, there can be osteophyte, there can be indentation with distal cam. There's a lot of different types of cam pathology, but there's always rim pathology, and so we deal with the rim all of the time. And as I said, 70% of our athletes we deal with the cam. When you go down to the cam, you're opening your capsule more. You need more access to the distal next to you. You've got to make sure it's worth it in order to try and go down and correct it completely. And so there are certain types of cams, especially the low cams, we're avoiding. In certain types of borderline dysplasia, even the proximal cams we're avoiding. So certainly the practice is evolving over the years, where in the past the primary driver of our practice many years ago was the cam and not the pincer. Now it's the opposite.
Thanks. Damian, probably you could take this one on. Would any of the speakers recommend a source of evidence for the longer-term outcome measures following hip arthroscopy for FAI syndrome beyond 2 years?
Yeah, there's a few papers that have been published that talk about up to 10-year outcomes. And they're pretty good, actually. It looks as if people who do well at 2 years, in most cases, are still doing well at 10. And I suspect that's because the ones who have either significant degeneration in their joint or other factors of the sort that Paul was talking about have been selected out as bad outcome patients by 2 years. Having said that, I think that having a good outcome at 2 years doesn't mean your hip's going to last forever. I think we have to recognise that all of these patients start off with a hip that's got a poorer prognosis than someone who's never had any problems with their hip.
And final question by Doug Dulnam. Is there any role of bilateral simultaneous open Smith-Peterson procedures for large cams, and as it's much quicker with a good capsule repair? I think probably all 4 of us have do not indulge in that kind of a procedure, so we may not have the experience to answer that. But Paul, go ahead.
no experience of that whatsoever.
Damian, any thoughts?
Well, Doug is talking about minimal access anterior hip surgery. And there are a few people around the world who have made a big success of this. But I think most of us in the hip preservation community feel that it's the worst of all worlds. You're neither doing endoscopic surgery with all the advantages of the minimal access, nor are you getting a really good view that you would do if you had a surgical dislocation. Now, I think that is a bit controversial, but I think it would be fair to say that the majority of surgeons have moved away from minimal anterior approaches. I guess if you do it and you're really comfortable with it, there's no reason why you shouldn't do it on both sides. Although that seems like doubling the difficulty to me.
Excellent. Right. We've run well over time, but thank you all for excellent talks. And thank you to all the delegates who've attended as well, all 40 of you staying for the whole hour for this. For those of you who could not attend, it's available on Panopto via the BHS website. And once again, thanks to all of you and have a lovely evening. Thank you.
Thank you. Good night. Good night.
Right.
Good night.